One of our major system-wide initiatives under One UNC Health is to reduce unwarranted care variation. Much of this important work is being done under the umbrella of our Care Redesign Department. One of our major care redesign initiatives for the coming year is to reduce the unwarranted use of red blood cell transfusions. As a surgeon, I know that red blood cell transfusion, when done appropriately and in the right indication, can be life-saving. But I also know that when given unnecessarily, it can cause significant side effects for my and your patients. I strongly support, and I hope you will strongly support, this care redesign effort to improve our red blood cell transfusion protocols and reduce unwarranted transfusion. Thank you.
Blood transfusion is one of the most common procedures performed in hospitals across the U.S., but many of these could be avoided. Studies show that 40 to 60% of blood transfusions are unwarranted, and the Joint Commission, American Medical Association, and Choosing Wisely campaigns from multiple professional societies all identified this overutilization as a problem. There is currently significant variability in the practice of blood transfusion despite the availability of evidence-based guidelines. Many of us were taught in medical school that it is important to maintain hemoglobin level above 9 to 10 and to give patients 2 units of blood when transfusion is needed. However, current evidence shows that a hemoglobin threshold of 7 to 8 yields clinical outcomes equal to or better for asymptomatic patients. For many stable, non-bleeding patients, 1 unit of red cells may be enough and even be the safer option. In fact, the evidence for a more restrictive blood transfusion approach is overwhelming. There are numerous randomized trials conducted in diverse clinical settings involving several thousand patients collectively, with results published in leading journals like New England Journal of Medicine and JAMA. The conclusions of these are consistent. Restrictive blood transfusion approaches are safe and often lead to better outcomes when compared to a more liberal approach.
One reason for their overutilization is the risk of harm is often underappreciated. Studies show that blood transfusions can be associated with negative outcomes, including increased mortality, infections, and length of stay. Donor selection and screenings have dramatically reduced infection risk, but acute lung injury and circulatory overload are major sources of morbidity and mortality. There are also adverse non-infectious reactions like allergies. Some less rigorous population-based studies have even suggested that transfusions may increase the risk for cancer recurrence and DVTs of PEs. For the reason of patient harm alone, we should always aim to transfuse no more blood than necessary.
UNC Health's Care Redesign Patient Blood Management Initiative aims to improve the care we provide to our patients throughout the system while reducing unnecessary costs. One simple way to do this is to make single-unit transfusions the standard for non-bleeding hospitalized patients. You can still give 2 units, but we're asking you to give asymptomatic patients 1 unit at a time. Transfuse 1 unit, reassess the patient, and then decide whether a second unit is necessary. We can really make a difference by only ordering blood when the evidence supports it and transfusing 1 unit at a time. We know that changing long-held habits and practice patterns can be challenging, but we need your help and active support. Make sure your transfusion decisions are influenced by symptoms and hemoglobin concentrations, and don't use 2 when 1 will do. Visit the Care Redesign Intranet page to learn more. Thank you.